Okay, if it's medially rotated, it's not going to rotate laterally. And we'll notice that when the patient's adducting their arms. Okay, doing a bilateral comparison. It's like you're going to try to get water out of Charlie. Okay, if it's laterally rotated, the patient's going to lay prone. We're going to come in here, we're going to contact here, and we're going to be pushing these in. And this is more of a passive movement, so I'm moving it in, and I'm seeing if this side rotates in as well as the other side.
Medial, you just contact the other side.
If it's medial and you're making an adjustment, you're going to contact right here, make your correction. If it's lateral, you're going to contact here and use your thenar to make the correction. This side your pisiform, this side your thenar.
Okay.
There's prone moves we can do too, and I showed you that we're not testing you on that. Anything else?
Just all of them, really quick.
Clavicle, what we're doing is we're just going to motion here while the patient shrugs their shoulders and protracts and retracts their shoulders. We want to feel this movement. And the adjustment is right through here, P to A, through here. Make sure that the female cups their breast.
You're just contacting the scapula.
Yeah, I'm just stabilizing the scapula right through here as I'm making that adjustment. This one here, the clavicle, AC joint, I'm just going to stabilize the patient's arm against their body, and I'm just going to feel this should have a nice springy feel to it. If it doesn't have that nice springy feel, now if it's dislocated, you're not going to adjust that. I mean, I don't know if it would benefit them or not, but if it's just not moving right, it doesn't have the same spring as the other side, then you could just hold here, bring this up, and you're going to externally rotate just like this. And that will hold this in place. And you should feel that move. Some people bring it up like this, stabilize here and here, and then adjust down on it like this. But for the test, I just want you to hold this, and it's a fraction. The same as if you have a posterior clavicle here at the SC joint, you're just going to extend, and that will push that out. Make sure you have something behind the patient.
Do you have a thrust here when you're doing? No, you're just extending it.
No. Okay. If you have an AI shoulder, the thrust is going to come up and through like this. 2 hands up. Just set it back. Okay. Posterior ulna. You should use a marble shooter's grip on this, or you can use your thenar. You can use this type of a grip, like putting your hand into a little cup, hold the patient's arm supinated and thrust up like this, or again with a marble shooter's grip, thrust through this way. If it's a posterior lateral radial head, keep the patient's arm down at their side, come in like this with a marble shooter's grip right on here, and you'll thrust straight through. P to A and lateral to medial.
And the medial.
And you are supinating that.
Yes, you're supinating that while you're thrusting. It's supinated and you're thrusting.
And then the ulnar, medial, lateral, ulnar.
Yeah, if the ulna is medial or lateral, if it's medial, you can just stand here and you can pull this back. So it's coming P to A, but it's also coming medial to lateral. And if it's gone lateral, you can push it with your thenar. And instead of coming straight up, you're adding some of this motion with it. See if that will bring that to a more normal position for the patient.
You're just contacting on the medial side.
Just you're moving a little bit either here or here of the contact
So
point.
when you were
Normally your
doing
contact point's right here. You're going to be here or here if it's gone medial or lateral.
When you were doing the posterior,
Yes.
you were contacting the same place, weren't you? When you
No.
were-
If I'm